Hi everybody, I hope you can all hear me. I'm Eamon Breslin and I'm part of the conference, the committee for the British Intrapartum Care Society. And it would be obviously much nicer to be having these presentations in Belfast as planned, where we can all sort of socialise and have drinks, but obviously the worldwide pandemic is not letting us do that. So instead we have a series of webinars throughout the month of November, focusing on several pertinent themes running throughout intrapartum care. And tonight's theme is on preterm birth. And facing some of the dilemmas that we all see on our day-to-day jobs as clinicians, and also a talk from a neonatologist to address the changes that have occurred in resuscitation and resuscitation guidance for preterm infants. I'm now delighted to ask Katie and Morris and Vicky Hodges to come and discuss their presentation, which is on incidental finding of bulging membranes, a clinical dilemma. Over to you, Katie and Vicky.
Thank you, Eamon. Can I just check you can hear me and you can see the right slides?
Yeah,
Yes.
absolutely.
Yeah. Great, thank you. So as Eamon said, it gives us great pleasure to talk to you about this very difficult clinical dilemma on behalf of the C-STIX2 trial team. So to start us off, I'd like us to consider the case of a 28-year-old primate who's a low-risk pregnancy who presents at 20 weeks to maternity triage with a feeling of pressure and difficulty passing urine. On speculum, she's found to have bulging membranes with no uterine activity, no obvious signs of infection and no bleeding. And Louise, I think, is going to just launch a poll for us, for you to just say, in this woman at 20 weeks gestation, which of these do you think would be the most appropriate treatment? So you've got a choice of emergency, or you might know as rescue cervical cerclage, expectant management with antibiotics, progesterone, or you're going to be honest and say you really don't know. So just give a few more seconds. I've got 80 of you voted out of the 117. Having a little bit of change, a little bit of reduction in people plumping for cerclage. Okay, don't seem to have much movement there. So if we could end that poll, thank you, Louise. So 50% felt emergency cerclage, 19% expectant management, and then kind of a split between the other treatments. So what we're going to do now is if we just move on to the next slide and the next poll, thank you, Louise. So this next poll will look very similar, but I just want you to answer quite honestly. If this woman was now 23 weeks gestation, what would be your choice of management? So same question, same treatments options, but she's now 23 weeks gestation. So all voting a lot quicker, so you all feel a bit more confident in answering this one. And I think we'll end it there. Thank you, Louise, because I think what we can see there is that we've, so emergency cerclage still the most frequently chosen, but definitely more of an even split across the treatments. So we can end the poll. Thank you, Louise. So I think what's helpful to think about is what are the potential causes of second trimester miscarriage, because that is what this woman is presenting with. So different scenarios have different causes, and it really depends whether a woman presents with a viable pregnancy or not. So some of the causes might be a structural anomaly, a chromosome problem, a genetic problem, or a maternal disorder such as diabetes or phospholipid syndrome. But often these end with an IUD and a woman presenting with bleeding and then pain. But for our case, this woman with painless cervical dilatation, we really need to consider infection. And for infection, we need to think of things such as ascending infection and urinary tract infection, and anatomical abnormalities, which might be a uterine abnormality or cervical insufficiency. and this may be related to previous surgery, connective tissue disorders, a uterine anomaly, or an unknown cause. And this can be demonstrated graphically or in a picture here. So we're really looking at a woman who's had a painless dilatation of the cervix, sufficient to allow the membranes to protrude through past the external os. So very different to ultrasound diagnosed cervical shortening, for which we have evidence for. And the real definition of cervical insufficiency is the inability of the cervix to retain the fetus in the absence of uterine contractions or labour. And that's owing to either a functional or structural defect. And it really is a distinct, rarely is it very distinct and a clearly defined entity, but it's often part of a larger, more complex spontaneous preterm birth syndrome. And in most women who don't have a predisposing factor, these cervical changes are often related to infection and inflammation, causing activation of the final pathway of parturition. So as I said, women usually present with little or no symptoms. They may be known or diagnosed as having or labelled as having cervical insufficiency because of a previous history consistent with this. But in the presenting case, they'll present with little or no symptoms, or symptoms that you might not associate with the condition. So it might just be some cramping, some backache, pressure, a discharge that's increased in volume or changed slightly. And we usually make it within 3 settings. So a woman who presents with sudden onset of symptoms and signs, and we find cervical insufficiency on speculum, or sometimes women who've had an endovaginal ultrasound for another indication and are found to have had the cervix to be dilated sufficient to allow those membranes to protrude. So again, not women who we're measuring the cervical length and the cervical length is shortened, but that the cervix is sufficiently dilated. So if we think about management, what should we do immediately? Well, obviously admit, because of the relationship sometimes with conditions that might cause IUD, obviously an ultrasound for viability. It's important to do a urine dip to look for any immediate signs of ultrasound, but also to send an MSU regardless of the signs of the urine dip to look for asymptomatic bacteria and to send an HVS. Bloods are a difficult one, but they should really only be done to be directed to other symptoms and signs. So for instance, if you're concerned about hypertension or if there's definite signs of infection. White blood cell counts and CRPs as a screening tool are not particularly helpful. It's really important that then the next stage is to counsel parents about this condition. This is because there is not a lot of very good, high quality information available to women on their usual sources, such as the internet, other women, even healthcare providers, around this particular condition. And so once we've explained to them about the condition, the difficulty in understanding why it's happened, we then need to be honest with them and tell them that the best management is not known. And then we need to make sure that if somebody is going to talk to women about a management plan or treatment, that includes talking about research, but also includes the fact that we don't know whether our treatments such as cervical cerclage work. And so somebody that has experience in this area needs to be counselling the women. I know you're going to talk about this later, but I've added the fact that we need to think about steroids and magnesium sulfate depending on gestation. And also I think we need to be able to consider whether the unit that this woman presents in, so your unit, is able to consider all interventions. So what might the potential interventions be? Well, there's always the do nothing, the expectant management. Antibiotics might come in there, as we've already seen from the poll. Potentially progesterone, depending on presentation. Tocolytics, amnioreduction has even been suggested as a treatment. And of course, emergently, cervical cerclage. So what's the evidence for these treatments? Well, as you can see from the length of this slide, very, very little. So there is no evidence to say that bed rest has any effect. For antibiotics, what we really need to think about is why might we be considering antibiotics? And I've tried to think myself about the indications that we might have in this scenario for antibiotics. So obviously, if a woman's presented with frank symptoms and signs of chorioamnionitis or a urinary tract infection, we would direct our antibiotic treatment to that condition. But for the most part, women may not have significant signs or a focus of infection. And then some people have suggested considering antibiotics as a prophylaxis around some of the interventions, such as the cerclage, or as a prevention when a positive swab result has been found. And often the positive swab results that we see in this scenario are either bacterial vaginosis or group B strep. And it's important to understand that the evidence that we have around those as infections, so either GBS intrapartum or BV as a risk factor for preterm birth, don't relate to this scenario. And so we don't know whether actually treating these when we find them in this scenario actually has any effect. In fact, they have shown that if a woman presents with group B strep and is then, presents with bacterial vaginosis and then is treated, that actually at this time might increase the risk of further chorioamnionitis and other adverse events if the woman then goes into preterm labour. People have also obviously looked at the vaginal microbiota, and we've seen a lot of that evidence around sort of predicting women at higher chance of preterm birth. And again, people have looked at if you find what we would call an unhealthy microbiota, so one that is lactobacillus depleted, in women who then go on to rupture their membranes, that again, treating them with antibiotics such as erythromycin has actually been associated with higher rates of chorioamnionitis. So the evidence for antibiotics is not really there, and I think we have to really consider a scenario of what we're treating before we consider them. So progesterone, this could be considered as a treatment alone or as a treatment in combination with cervical cerclage. Again, all of the evidence that we have around progesterone is for women who presented with that shortened cervix or who are at risk of preterm birth, not women who present in this scenario. And there really is no evidence around using this in combination with cervical cerclage. For tocolytics, it's mainly around indomethacin, with the thinking being that if you've got some uterine activity, indomethacin might help reduce that, and also that you can help reduce fetal urine production, and therefore that the pressure effect on the membranes, and also we need to consider that this might have a possible negative effect on the inflammatory response that's occurring. Because of the pressure within the fetal membranes, people have also talked about amnioreduction, but again, the potential negative from that is that this may be an infective type pathway, and that by doing an invasive procedure may increase the risk of progressing to full chorioamnionitis. And then, of course, the one that came up in the poll is emergency cervical cerclage. So just to remind you that emergency cervical cerclage is different to when the cervical shortening. The membranes are prolapsed, and so the first part of the procedure is replacing the fetal membranes, grabbing onto the cervix, and then putting a suture that supports the membranes to remain within the uterine cavity and occlude the cervix. The problem with this is, as the etiology we've discussed, that often this is a pathway related to ascending infection. And so there's a risk that by replacing the membranes and occluding the cervix as such, that actually we're interfering in that pathway and increasing the risks for the woman of severe infection and sepsis. Often the cervix is quite dilated, and so by grabbing the cervix and pulling it down enough to insert a suture, we run the risk of cervical trauma, and also because of replacing the membranes, the risk of rupture of membranes, which in some series has been reported up to 50%, and therefore actually accelerating the pathway. And all of this leads to the fact that actually we need to consider that cervical cerclage may actually be at best, ineffective, or at worst, possibly harmful. So as you know, we're running C-Stitch 2, which is a trial of emergency cervical cerclage to prevent miscarriage and preterm birth. It's an RCT comparing to standard care, and it's for women with the condition that we've talked about between 16 and 27 plus 6 weeks, because that's the nice guidance as to when this procedure can be considered. Importantly, we're following women up to 2 years, their babies, up to 2 years of age, because of that risk, as we've said, about potential adverse effects of keeping babies in an infective environment. So looking at general health and neurodevelopmental outcomes, and also looking at those complication rates, including iatric rupture of membranes, women who get to theatre and can't actually have the treatment inserted, and also are there any predictors of successful placement, such as severity of dilatation. We've just completed our 2-year pilot, which had those objectives there and involved a qualitative process evaluation, and I'm just going to give you a few quick results of those. Just quickly, why did we need a trial? Why are we asking you that question about emergency cervical cerclage? Well, there's only one RCT so far that has looked at cervical cerclage. The rest are retrospective observational studies. That RCT only had 23 women, and although the results looked promising, so both increasing mean randomisation to delivery interval, reducing preterm birth and reducing adverse neonatal outcome, there was a significant heterogeneity in the inclusion criteria. There was a significant use of other treatments in one arm only, and a significant number of multiple pregnancies within this RCT. So we can't extrapolate that to the population that we're talking about. Just very briefly about some of the challenges. One of the challenges we had is our sample size, so actually trying to determine what the relative risk reduction might be, and actually what even the event rate might be in the conservative arm. So what's the normal pregnancy loss rate if we do nothing? And also determining what we might need to do is to show as an effect size to make it that actually cervical cerclage is beneficial. So we did plump for a sample size of 260 women. Inclusion and eligibility criteria are very, very broad and very, very pragmatic. So we don't make any definite definitions of what we would consider contraindications, particularly related to vaginal bleeding, labour, signs, or evidence of infection. That's up to the clinician as judging that the woman would be eligible for a cerclage. And we're also very pragmatic about the use of the other treatments that we've particularly discussed, so progesterone, antibiotics and tocolytics. You can use those as you would do as part of your standard care. So we're just coming up to the end of the pilot, and where are we up to? Well, 207 women have presented with this condition, 115 have been eligible for the study, of which 75 have been approached, 21 consented and 19 randomised over a 16-month period. What does that mean? Well, it means that on our eligibility criteria that even are quite wide, only 55% of women with the condition are eligible for a cerclage. So they might present either outside the gestational window as a multiple pregnancy or contraindications to cerclage. And of those eligible, we're only approaching 65% of women about a trial. So we're making decisions about intervention prior to considering the evidence. Of those that are approached, 28% of women consent. We anticipated that this would be 30%, so we're not too far off that. I think one of the other significant results about the C-Stitch 2 pilot is that what we found is, although we're open in 34 sites, actually only a small number of sites have actually managed to randomise to the trial. So 76% of sites have eligible women and are able to screen, but of those, only 27% are able to randomise. And in the sites that can randomise, the conversion rate to receiving the treatment can be as up as 50%. And I'll discuss later what I think that might imply for us. Just to let you know that of the women that we've randomised, we're able to achieve 100% primary outcome rate, and we've had no concerns regarding safety or withdrawals. So once you're in the trial appears to safe and women appear to be happy to stay within it. So I said that we had a qualitative process evaluation, and that's just to show you how many women and clinicians that we've had within it and the spread of them across both arms of the trial and women who've declined to take part in the trial. And I've not got time to let you read these quotes, but what I will go on to in a minute is just explain the themes that have come out of this, because they are quite informative for thinking about this condition, and also the kind of quotes that we've had from healthcare professionals. And again, I'll explain the themes. So what we've shown is that this decision-making process isn't easy. I think we were going to know this, but actually it was interesting to know what sort of things influence the decision-making of both women and healthcare professionals. We also noticed that there was a fluidity of equipoise. So what I mean by that is clinicians sometimes weren't in equipoise at all, or sometimes their equipoise changed according to the change in the woman's clinical condition, or more importantly, what we saw often is that their equipoise changed related to the gestation of the woman that was presented to them, or related to that woman's previous history. And what we found is that actually people were trying to make predictions about outcomes based on all of those, and then make a decision about what they thought the outcome might be, and therefore whether they would consider a cerclage or not. We also really found the importance of terminology in discussions around how and when approaches to the RCTs are made. So this goes back to what I said about making sure that somebody who understands the evidence, who understands the treatment options, and also understands the condition is the person that talks to the women, whether it be about the trial or not. We also found that in some sites where they had originally thought that they weren't an equipoise or originally thought that they weren't being able to randomise, actually taking part in our minimal data set and receiving the trial information actually changed their practice. And so that we feel that this is kind of around education and understanding the things that I've talked to you about today. A busy side, but just to say that we've made some recommendations thinking that might be generalisable to practice, but also to carrying on the study, and that is that women ought to have the opportunity, wherever they present, to have cerclage considered, ideally as part of a trial, but that might mean that we need to work as networks because not everywhere has this availability, but that everybody needs to have knowledge and awareness of the current evidence base. That people need to understand that equipoise does change across datational cut-offs, but that doesn't mean that it's the same across all sites, and actually to work as a network to provide women the opportunity, and that we need to consider an observational cohort because we need to answer these questions whether we can answer it with a randomised trial or not. So just to let you know that we're currently being considered by the HTA to consider going to a RCT with an observational study, and we hope to have a decision about that in the next few weeks. And this is just a quote from our PPI, and I think what this just demonstrates, particularly that in bold at the bottom, is why it's really important that even if we don't manage to successfully randomise, that actually we get the information that these women need and that we provide them with the best counselling and about the condition and treatment options at the time they present. So I'd like to go back to our case, and if Louise could bring up the third quiz for me. That's to remind me what I'm asking you to do. So we're now going to give you the same options that you had before. So it's the same case, a woman at 20 weeks, painless cervical dilatation, no signs of infection or labour. What would you now do? Well, you're either now all being really, really kind to me because you want me to shut up, or actually I've convinced you regarding the evidence. So I think we can end the poll there before I lose. Thank you, Louise. And so now what I'd just like to tell you in the final minute is what are we actually doing across the UK? So I've said that actually practice varies quite considerably. These are actually the results of a survey that we did in 2017 of the 60 sites that we're currently recruiting to C-Stitch 1. So that's the trial of suture type with ultrasound indicated cerclage. And 47 clinicians responded. And we asked them at that point whether they wanted this question, which I haven't addressed for this very reason, about whether they want to wait 24 hours before they put the cerclage in, and it was very split between whether people waited or not, whether anybody had a preference for suture type for emergency cerclage, and there was no strong preference. But also we looked at operator experience and found that even at that time, 82% of clinicians felt that there should be dedicated operators for this type of procedure. But also we understood that defining experience was difficult because there's no national guidance. It also revealed that there was a great difference in how people perceived experience should be. So some people felt that having performed 0 to 10 of this type of cerclage gave them experience. Other people felt that it had to be much higher. Sorry, that was the experience. So people thought that there was a baseline experience, but actually the experience significantly varied across the UK. We also did ask the question that we've asked you about what people would do around adjuvant treatments, and the majority of people said that they would prescribe antibiotics at the time of insertion, but there was great variance in use of tocolytics and progesterone treatments. And as I said, we've adopted a pragmatic approach, but we'll be able to look at that in C-Stitch. So finally, just what do we do next as an obstetric community? This was just published yesterday from Zarko Afurich's group in Liverpool. And the reason that I've put it here is because it's an excellent paper around preterm birth, but it all focuses on prevention. So this is the problem with some of our research at the moment in preterm birth. We're doing great research around preterm birth prevention, about preparation around the time that women present, which we're going to hear about. But what we don't know is in this group of women, what do we do? We also don't know how to manage singletons versus multiples. And I want to leave you with the thought that actually the question may not be whether emergency cerclage is effective, but actually in whom is it effective and what are the predictors of success of the treatment. And that might be around the presenting factors that women have, such as dilatation or previous history. But actually, we might also consider that alongside that, it might be us and our experience in placing this suture. So thank you for listening. If you want to follow us on Twitter, that's our Twitter handle, our website, our email addresses. Just a little further plug for the BMFMS BAPM conference coming up, and just to say that C-Stitch 2 is funded by the NIHR, and the views that are expressed are mine and not theirs.
Katie, thank you so much. That was an amazing talk. There was one question that came up on the chat, and it was, why would you not recommend CRP and white cell counts are used for screening for asymptomatic infections?
I think it's because they have to either, it's the problem when you do a test. So it either has to be completely normal or completely abnormal for it to be able to help you make a decision at this time. And what we often find is that when women are presenting, because of it's going down the labour type pathway, that there are mild increases in white cell count and CRP at the time that they present that don't then translate into an infection. So I was being a little bit challenging, and I was hoping somebody was going to ask me that question. I accept that if a woman comes in and has a CRP of 400, you have to presume that she has an infection. What I'm trying to get people to think about is that the woman that comes in with a mildly raised white cell count and a mildly raised CRP, that shouldn't be influencing your decision making. We should be really thinking about this woman as a whole, and whether actually there are frank signs of infection to go alongside that. So don't just trust the test, and use it as I said, as a screening tool to help you make what should be a clinical decision.
And we have one more question. So we talked about the importance of education for practitioners and clinicians on the shop floor, especially sort of midwives in clinical areas. Are you aware of any resources to help with educating midwives and our doctors?
Yeah. So one of the things that we're going to do within C-Stitch 2, which will actually be a general resource, is we're currently working with the Tommy's charity, and we're going to record some videos that are around the condition that you will be accessible on their website, that will explain the nature of the condition, so that if a woman presents in the middle of the night and people aren't experienced, they can be directed to this resource. And then the second one will be around talking about management and the options of the trial. That obviously doesn't present the replace the experienced obstetrician coming to talk to them, but we recognise that these women present often in the middle of the night, where it is our more junior colleagues who might not have this experience, might not have this confidence, and these resources can be used for them. And then the second thing that I just say is around the sort of learning how to do these and how we do that as a community. And some of our lovely other obstetric colleagues, such as Andy Shannon and Graham Tideman, have worked with limbs and things to develop a simulator. So C-Stitch 2 may give us the answer in an RCT about emergency cerclage. That would be lovely, and I'll retire if that happens. But actually what we will do is ensure that it gives us these answers to all these other questions, and at least gives us good resources and good guidance about what's the best thing to do, even if it can't tell us immediately what's the best treatment. And I can just see Penny saying we're going to continue to recruit junior doctor champions. So yes, we are. And actually the CRN have agreed to let reproductive health and childbirth be part of the associate PI scheme. And as soon as that's signed off with RCG endorsement, you'll actually be able to do it in a much more formal way as an associate PI as a junior doctor.
That's brilliant. Excellent. And the comments on the chat were about what an amazing talk this was. Before we go, what type of cerclage are you going to recommend? A McDonald or a Schrodker? So
we haven't looked at that. Obviously, most people know that if you're putting in a cervical cerclage, particularly at advanced dilatation, you can really only get in the McDonald's. The same in C-Stitch 2, we don't recommend the type of procedure that you put in, but we are recording that. It's very, very different, and the access, particularly to Schrodker, is very, very different. But they're sort of things that we will look at, even if it isn't in a powered way in the RCT. Great, thank you. I asked that because Penny's obviously a ninja. Rescue Sarod. Well, so I trained to do sutures in Leicester, so I know how to do Schrodkers because of Penny and people there. So, Vicky, thank you so much. Pleasure. We're going to move on and hear from Nigel Simpson, who's going to talk us through the dilemma of delivering the preterm infant. And I hope Nigel can now share his screen. Brilliant. Thank you.
Thank you very much, Eamon, and thank you very much, BICS, for inviting me to share my thoughts on delivering the extremely premature baby. it goes without saying that we are dealing with some of the highest risk mothers and babies at this stage of pregnancy in the late second trimester. And I think probably what runs through all of this, the elephant in the room, is what we see displayed here in part, which documents the fact that although most of our neonatal deaths occur in births from the second trimester, most of these babies are going to survive. That is the fact, because of course our neonatal colleagues are remarkable, and because things have advanced so far in recent years, that most of these babies are going to survive. Now that is great, but it comes with a price. I think these graphics are really helpful in counselling parents, but you will notice, of course, that when we see the donuts on the right, and we're talking about what proportion of the babies born at a particular gestation will have disability, it's marked as severe disability. And of course, there are shades of disability which may be more or less acceptable to parents at that stage, but which will mark that baby's chances of a sort of, if you like, a life as equal as everybody else in later life. And I think this is a key issue that we have to consider as a community. For example, if you look at the preterm brain and you do MRs at various stages within, this is just within the third trimester, you can see that the starting point over here is a brain that is as smooth as a billiard ball. There are none of the sulci and gyri that emerge throughout the third trimester, in which you can see very elegantly displayed in the images acquired later in the third trimester. And in the third trimester, there is an enormous expansion of connectivity and neuronal migration and maturation that is not just responsible for motor function and intellectual capacity, but which is very much responsible for that baby or that infant, that child's ability to interact and communicate and socialize along with other children of its age. And it's probably these elements which are receiving more attention now as the birth cohorts from extremely premature babies are studied longer and longer. So, for example, we know that babies who are followed into adulthood find it much more difficult to develop emotional attachments and to succeed in close relationships, for example. These are really important elements of growing up and being a happy and healthy part of society. And of course, these are just the sort of issues that we ought to be considering and factoring in when we work out how we can optimize the care of these very at-risk mothers and babies. I think this is probably most elegantly shown in Gordon Smith's seminal work from Scotland, looking at the impact of the gestational age at which you were born with your need for educational support as you go through school. And you'll see that the group that we're considering at the moment, those who are born within the late second trimester, their need of state support within the classroom was 1 in 2. And that is really quite a remarkable statistic. I think the graph doesn't really pay full sort of tribute to the risk, because of course that scale on the y-axis is a logarithmic scale. And so you'd expect if it was drawn to true scale, it would be going through the roof or your screen at the moment. So when we're making decisions and we're discussing with parents as a multidisciplinary team, we must be careful that this is not just about survival. It's about survival with as good a prospect as possible for that baby to participate and feel that he or she has the chances that everybody else has later in life. This is the other rather sobering fact here. These data are from the cohorts from sub-27-week deliveries in the UK. And these babies were followed through to the age of 20. And what it documents there is their cognitive test scores, their IQs, if you like. And you can see that there are two groups there. The group at the top, the blue and the green lines, which are babies who are born term, and those within the, those who are red or orange, who were born at this very early gestation. And you can see one of the striking factors is that there is no catch-up. It's not like growth or other elements which may be commonly looked at as a child develops. The brain, I'm afraid, is not as plastic beyond birth as we would wish. And so injury that occurs either before or during birth or in the neonatal period will be fixed, and there is very little improvement that one can make from that. And that is something that is, as a maternity service, both obstetricians and midwives, we must be highly aware of in any care that we give, and must spur us on, especially to consider how we look after the fate of these babies. So who's doing most to progress towards that? Well, I'm afraid if this was a fight, then the neonatologists would have won it by a full knockout after about the first round, because the number of innovations that have come into neonatal care change year on year and year, and have enabled these very small babies' survival. From the obstetric point of view, we really don't have much to come to the table. It's mainly limited to glucocorticoids and magnesium sulfate, which I'm not going to talk a lot about today because we are very well aware of the benefits that they bring. And indeed, within the recently published quality improvement toolkit from BAFM, we have the perinatal optimization care pathway, which understands that and has made it very clear to the maternity services that the ways in which we can truly improve the sort of the outcomes for these babies are, first of all, getting our history and our triaging right. And then in terms of the peripartum period, making sure that they are going to be in a place where they can be cared for after birth, that we give steroids in an appropriate manner where possible within 48 hours of birth, that we give magnesium sulfate, and that we give intrapartum antibiotic prophylaxis to cover group B strep. But that's as far as it goes for the moment. And of course, the elephant in the room, as anybody who has spent anxious moments on a delivery suite with babies who are delivering at this stage, is the mode of birth. How is that baby going to be born in a fashion that gives it the best possible start in life? So if we look towards our colleges and our societies, there are three main documents which I'd point you towards. First of all, the ACOG guideline, which was published 3 years ago now, which I think covered very well the sort of probably the state of play in the US with regards to periviable birth. The management of breech presentation, of course, as we'll see in a moment, is an important consideration at these gestations. And I thought they gave a very balanced account of the options available in that Green Top guideline. And then, of course, last year, BAFM came out with the perinatal management of extreme preterm birth before 27 weeks. And I think in that document, again, gave a very helpful and nuanced account of what the various issues are that one must consider as a team before making decisions about timing and mode of birth. But actually on the actual decision-making on mode of birth, again, it remained reasonably silent. And I think one of the problems of that is that we're left in a situation where it's not actually talked about that often. And that, as we'll see in a moment, can lead to problems. We have to recognize that our understanding of birth at this stage of pregnancy is incomplete. First of all, it's not a common situation. In a reasonably sized maternity unit, say with 5,000 deliveries a year, you're only going to see a baby born at this stage of pregnancy every couple of weeks. And if you factor in the situations where, for example, that delivery is planned or is anticipated, it may be every month or two that you're actually in the situation of caring for a mother during the birth process. And so the individual and corporate knowledge of what is normal in those situations is not high. And secondly, the diagnosis of labor is difficult. We find it very difficult to understand whether the rules that we apply at term simply don't apply in this extreme preterm situation. That is mainly because, of course, the baby is smaller and can slip through a cervix that's not fully dilated by any stretch of the imagination, and that, as you know, will cause problems. The progression of labor is also different. We're well aware of mothers who can have a cervix that is significantly dilated beyond 5 centimeters and yet can remain in that situation for some days. And I'm sure many of you will have extensions of pregnancies that go beyond that. So the progression of labor is different to that which we're familiar with at term. Coexisting compromise is very common. So obviously it's a pathological situation for mums to be giving birth at this stage of pregnancy. So bleeding from placental abruption, infection either arising from colonization of the uterus or systemic infection, and fetal problems such as growth restriction are all factors in this situation. I think the other issue that we find very difficult to shake off is that there is perceived benefit in extending pregnancy, and that is something that afflicts us all. There's just something instinctively that feels right about being able to extend the pregnancy further, which simply may not be true at all. But it is a perceived wisdom, and that, I think, hampers our ability to think clearly about what's best for the baby. And also the sort of technical skills that we may need to safely give birth to a baby at this stage of pregnancy. Well, because we don't often see it that often, then individual practitioners are few and far between, and as a result, these technical skills are not exercised as much as they could be. Certainly not to the extent that we, for example, are adept at controlling postpartum hemorrhage or the management of severe hypertensive disease. We just don't get the practice at it, and it's very difficult to provide mock-ups of these situations. If we look towards the sort of traditional sort of source of all wisdom, the randomized controlled trial, I'm afraid it is an empty well. This is from Zarco's Cochrane review. Well, the update was last year, but as you can see from the studies that were chosen originally, Zoe Penn's original 1996 studies, Zatnick's 1993, and then for a cephalic study, you have to go back to 1984. Unsurprisingly, there is maybe a trend towards benefit from C-section, but the numbers are simply too small to reach benefit or meaningful observations. So let us have our own Delphi consensus. I think I saw about 180 folks on the call. So let's take Mary here, who is not comfortable. She's 38 years old. She's in her first pregnancy. She's 25 weeks in a day. And she's come into our triage center with vaginal spotting and lower backache. And when the team have carried out a speculum examination, they can see bulging membranes. They have quite rightly considered their situation and have admitted equipoise, and so they have randomized into C6-2, which has given her expectant management. So Mary is admitted, and she's given a course of antenatal corticosteroids, and what then happens over the following 24 hours, this discomfort increases. She is eventually requiring opiates to control this. A further examination realizes that the cervix is now 5 centimeters dilated, and just to give us further kittens, it is a breech presentation. So the poll I'd like you to answer, I only have one question to answer, which hopefully will be coming up on the screen now, please, if that's okay. So in your unit, what would normally be recommended? Now, I realize this is an unfair question, but these are difficult questions. But in your unit, what would normally be recommended? Would you expect management and await, if you like, a spontaneous outcome, i.e. going into labour at some stage, either today or next week or next month? Would somebody want to, or would a unit prefer to induce labour with limited fetal monitoring, restricted, for example, to intermittent auscultation to allow the neonatal team information about the baby's progress through labour and their options at the time of birth? Would labour be induced, but if auscultation sensed profound bradycardia, then there'd be a recourse to C-section? Or would we expect our unit to go ahead for a planned caesarean section? Now, I can see we have over 100 who have voted so far. That is very good. Up to 111, Parson Nelson, that's great. This is looking like, yes, this is looking like an Ian Botham innings at the moment. And we're up to 120, that's excellent. And I think we're getting to the sort of situation where I think we're going to not see much change. So I think we'll hold it there, thank you. I think we've got that. So for most of our units in this 25-weeker, we would be adopting an expectant approach. And we'd await spontaneous onset of labour. So that's about 3/4 of our poll would choose that, and about 1/5 would go for a planned section. So let us, yes, can everyone see that? I take everyone has seen those results, yeah. So let us continue. So let's see why that compares with the rest of Europe. Doesn't everything in life revolve around Europe in recent times? Well, perinatal management is no different. And the peace study, which was an EU funded grant in 11 countries, it looked at practice about 10 years ago. And what it wanted to know, or this part of it wanted to know, was what happened in births between 22 and 32 weeks with the breech presenting, what happened in those pregnancies. And what they found was that the further on in pregnancy one got, the greater the chance of the baby being delivered by C-section. And that ranged from the time that we looked at now from about 35% right up to 77%, well, 78% when you got into the early third trimester. So that was very interesting, because what they then also did along with this is that, of course, they couldn't resist sort of seeing what happened in different countries. And what they found was that, of course, we couldn't be like everybody else. If you looked at the practice in Britain, which, if you want to know where it all took place mostly in Trent, in the centres there. For most of those centres, well, as you see, the aggregate of those centres was a very low C-section intervention until one saw about 50% at 26 weeks and then upwards. But what you notice that in the composite of all the other European countries who contributed, the rates were much higher from a very early stage. And when the group looked at this further, what they found was that in just about all the other centres outside of the UK, there were protocols which talked about mode of delivery, and guidelines were given to the perinatal teams, which included, or if you like, it gave license, it gave permission to consider mode of delivery in the discussions they would have with parents, and explicitly offered in many countries a caesarean section. Now, of course, we talked about breech presentations because that's the sort of stuff which keeps me awake at night if I know that somebody in Mary's situation is on delivery suite. We have to realize, of course, that it's commoner at early gestations. In the EpiPage cohort from France, the chance of the baby being in the breech position at this stage of pregnancy was 40%. Now, the problem with that is that we come across two situations which frankly terrify me, and I think we all hope we never have to deal with, and that is cord prolapse at this stage of pregnancy, or the risk of head entrapment. Now, these are not, I'm afraid I couldn't get the incidence of cord prolapse anywhere. I suspect it's probably small, probably single digits. But the risk of head entrapment is not a small risk. We're talking over 10% of vaginally delivered breeches at this stage of pregnancy will have head entrapment. Now, there are many reasons for that. I think the head tends to extend in preterm breech, and the legs and body provide a nice sort of graduated stretching of the cervix, which then closes in on the neck when that part of the baby appears in view. But head entrapment and the management of head entrapment is an emergency which you do not want to be leaving to your registrar at 2 o'clock in the morning. And you certainly don't want a baby who's been through that kind of birth. One of the problems, of course, is that you don't have the normal maneuvers that you learned in your training sessions. You cannot spin the preterm breech round like a marionette that one would sort of get away with in a term breech. So you just don't have those abilities. You're left with the rather frightening prospect of having to incise the cervix in a woman who's already likely to be without analgesia, is likely to be in a point of heightened emotion in a delivery room, which will not be the best time and opportunity to perform what one has read in the books mostly. The other problem, of course, is that there's a lack of what we would regard as high-level evidence. There are no RCTs in this area of note. We've seen the extant data, and that is less than 50 women. And so we do have to rely on other sources of evidence, and the observational cohort studies are the ones in which we have to deal with. And one of the problems about observational cohorts, especially at this stage, is exemplified in these data, which relates to the use of corticosteroids in this situation. And you can see, for example, that babies not receiving corticosteroids have a very poor survival compared with those who receive them 1 to 2 days before birth. And of course, what one would infer from this is that these are the babies who come in and deliver without any warning, maybe born to mums who have less structured lives, maybe in combination with bleeding. So there is always going to be bias in these observational studies, but they are still telling a story. So if we go back to the APICE cohort, and what we've looked there was a composite, which was a composite of mortality or severe morbidity. there was certainly a trend towards benefit of caesarean section that was present in 16% of those who had C-section versus 26% of vaginal births, although it crossed unity. But it did seem to be more striking in the 24-25 week group. So caesarean section did appear to have benefit. Now, again, they use propensity score matching, which tries to sort of sieve out the bias that a particular center would have. And when they tried to match babies of equal characteristics, they couldn't find that significance surviving that. If we look at systematic reviews and meta-analyses, this was the one published in the European Journal several years ago. 7 studies, good numbers, over 3,500 babies. Again, mostly from Europe, some from overseas. Again, the accumulated benefit seemed to suggest that neonatal mortality would be reduced by 30 to 40%. And you can see the absolute risk detailed there. The Express study in Sweden looked at babies born under 27 weeks, again, a good number in Sweden over a series of years, but this, of course, is retrospective. What they found, though, was that, and Sweden is the place which would section just about anything if they could. They're very aggressive there. But what they found was that there was an increased, I suppose this reinforced that belief, there was developmental delay at age 2 years was increased if you went for a vaginal breech. It was doubled. Now, again, you could say, well, if you haven't got experience of vaginal breech delivery, that's going to happen. But of course, the traditional breech delivery skills don't quite apply to this gestation. Again, if you look at another cohort study from the States in Missouri, and again, this is towards the end of the last century, all babies born between 23 and 25 weeks, there are about over 300 babies. And what they saw was that even if they stratified them across all weights, class 1, 2, and 3, the vaginally delivered babies had a higher risk of mortality than those delivered by C-section. You might say, well, that I could imagine that, because these are all the trapped heads and cord prolapses, and actually did survival improve? Did the chances of adverse neurodevelopmental outcome improve with time? Well, of course, they didn't look at that. They were just looking at pure survival. So were these section births selected? If that's the case, should it inform future practice? Well, you can see he's a bit struggling with that one. I would say yes. I think, yes, of course, these are selective and prone to bias, but I think they are our best guide to what we can discuss when we meet with women and we think through this with our neonatal colleagues. And I think we ought to be improving and focusing on training and skills in this area. Caesarean section is clearly a specialist skill at this stage of pregnancy. There may be elements of scale and access which you just don't have later in pregnancy. It won't eliminate head entrapment, though of course you can get yourself out of jail much more easily. There is a greater chance of having to adopt a vertical or classical incision. At about a quarter of cases that'll be the case, but it still means that 3/4 won't need it. There is, if you do a vertical incision, a longer recovery and increase perioperative complications. And there is a shadow cast on future pregnancies where there will be a higher chance of dehiscence. But still, that might not be a big deal in the grand scheme of things if you're dealing with somebody for whom this could be their only pregnancy, for example. And the overall risk pre-labor is probably at the lower end of that scale. We certainly need experienced colleagues assisting us or inputting into the process. This is not something for the boys to try on their own at 3 in the morning. So we need to think carefully about that. My conclusions are that the first thing that we need to think about as a community is including these issues in our preterm guidance, in our guidelines, and in the consensus we reach at in each of our units or LMSs. we need that consensus. We need this to be part of the discussion. That is, if you like, part of the number of boxes that we tick as we go down in considering how best to look after a mother in this very early labour. I think we do need to recognise fetal and maternal factors, growth restriction, multiple pregnancy, chorionitis, abruption. You could put preeclampsia, hypertensive disorders in that as well. All of which you want control of the situation, and caesarean section gives you that control. And I would say, along with the college recommendations, that these are situations where you may, not just in breech, but also in cephalic presentations, consider the benefit of caesarean section in relieving that compromised baby of the hypoxic insults, which will face it as it goes through even a normal labour, let alone one that will be complicated by cord accidents and head entrapment. It is important to think about these things well ahead of the event and to discuss this with your colleagues, maternity, neonatal, anaesthetic, and ultimately to having spoken with the parents about all the pros and cons, to follow the parental choice, because ultimately, and we come back to this initial point, they're the ones who are going to be living and looking after these babies after they survive, and the decisions that they make at that time and the care and support that we give them at that time will be vital. Thank you very much.
Nigel, thank you for that really thought-provoking presentation. There was a question on the chat that said, when we were talking about the resuscitation and outcomes of these premature babies, what do you think the role of bedside resuscitation will have on this?
Well, I think what bedside resuscitation does is that it stimulates everybody to really work as a team. I think there's increasing evidence that, well, personally, I will try and have the neonatal registrar scrubbed up beside me if I'm doing a section on a preterm baby, because I have no idea what to do with it once it comes out of the belly. All I want to do is clamp its cord and send it round the corner so I can get on with the operation. I have no idea how to care for a baby at that stage, but I know the neonatal team do. So if I have somebody who's scrubbed up and close by, because we don't have the portable resuscitators, I think that optimizes care in terms of cord clamping and initial oversight of the baby. If that resuscitator is right next door, that would be, if you like, provide that as well. But I have no data to support that. It's just my sense that that would improve team working between all the specialties involved.
There's two other questions that have come up on the chat. And one of them is, what are your thoughts on the use of the QUIP app in deciding on transfer to a level 3 unit in the antenatal optimization pathway?
I'm supportive of that. It's fair to say that the evidence is not, again, the sort of grade level that we would want for most of our other antenatal interventions, but there's certainly the early results coming out from a QUIP would support the use of the QUIP app in reducing the nice mandated transfers that we might expect otherwise, without the spectre of the woman delivering on the number 2 bus on the way back from the triage center. So yes, I believe equip and the use of, supports the use of the QUIP app. And again, BAPM have a very handy toolkit on their pages, which gives all the evidence that you as a unit may want to consider when you're deciding whether to adopt QUIP or not. But I think it provides a fabric for discussion with parents, for discussion between professionals about the best way to care for that mother and her baby. And that is particularly in terms of, for example, the use of steroids, which we know they are likely to have a kick in the tail if we use them too liberally.
Yeah. Nigel, one more last question and then we can let you go, but thank you for such an amazing talk. So the transfer of the extremely premature baby via ambulance with often a junior midwife is problematic and terrifies the midwife into the default position to hang on, which can result in poor outcomes. Do you know of any examples of training opportunities to try and educate our midwifery and junior colleagues in this sort of transfer?
No, I don't. All I know that I've been terrified in one of the back of those ambulances as well as the neonatal SHO a long time ago, praying to God that the chew wouldn't drop out of the baby's larynx on our way to a level 3 unit. So no, I'm sorry, I don't. I would hope, though, that we would make sure, I mean, my personal view is that if you have a woman who is that close to delivering, and there's a cot nearby, the best thing is probably to get on and deliver her in a place of safety. Even if your level 3 unit is squealing that they are full up, the first hour of care that baby receives is probably better in your overloaded unit than being carted off with, as you say, a terrified crew 50 miles away to another unit. My only view.
No, I agree. Nigel, thank you so much. We're going to move on to a neonatologist, and this is a consultant neonatologist now, not an SHO. And Cora is a consultant neonatologist in Cardiff who is also on the BAPM committee and is going to talk to us about the update on resuscitating the extremely premature infant. So over to Cora.
So thank you very much, Eamon. Yeah, I should have started now the video. So yeah, thanks for inviting me. And I'm so disappointed to hear that this is not, can you see the screen? Because my video keeps going off. Can you see me, Eamon? Can you see the slide?
Yeah, we can do, yeah.
Can see the slides. Okay, so thank you very much for inviting me, and I'm so sorry that we're not in Belfast this evening because I think that would be great. Hopefully you can extend the invitation again for that. So thanks for asking me to talk about managing the extreme preterm birth in 2020. So oh gosh, I'm trying to go on to the next. Sorry,
Cora, if you're struggling, we can we can share the slide.
Yeah, I'm not able to move it on to the next. Hang on a minute.
I can get Louise to share the slides that you've already sent, and then we can change.
I'll try to stop sharing for a minute, and I'll open it up again and see what happens. So work earlier. I don't know what's gone on here. Can you see that again?
I can see it.
Yeah, no, it's not letting me scroll on, which you did earlier. Yeah, perhaps if Louise could get it up. Thanks, Louise. Okay, so
there we go.
Thanks, Louise. Okay, thanks. So I'll ask you to move on, Louise. It won't be the first time we've done this together, so thanks. So as part of my talk, I'm really going to, really consider the wider view around this resuscitation or management of these extreme preterm babies in the delivery room and consider really the sort of progress in neonatal medicine over time. I'm going to cover shared decision making, personalised healthcare provision, which is a buzzword now, and really triangulating conversations between maternity professionals, neonatal teams and mothers and their partners. And there is increasing importance of the collective perinatal team approach and finally some marginal gains. So next slide. So before going on to talk about, to go into the talk in general, I just wanted to mention COVID-19 briefly. And many of you will be aware that there have been a number of issues raised by families about how upset they've been in relation to triage of care and age limits on people who are receiving intensive care, and saying that, you know, that their loved one didn't deserve this, because actually that person deserved a right to life and a chance to life. And I think COVID has also shown us really how different risk factors can affect how you can get the disease, and how also there's an unpredictability about it. And I want you to kind of bear that in mind as we go through the talk and really start looking at preterm management going forward. So next slide, Louise. And next slide. So I just want to scroll back now to 2006, where the Nuffield Council of Bioethics convened a working group to look at the ethical, social, economic and legal issues in clinical decision making around fetal and neonatal management. And next slide. And following on from those recommendations, BAPM developed a framework for practice around the management of babies born extremely preterm at less than 26 weeks gestation. And the data used for both the Nuffield Council and the BAPM framework were really the Epicure 1995 data, with some preliminary data on Epicure 2, which was from 2006. So next slide, please. So this is essentially the pathway. As I say, this was from 11 years ago, and you can see on this now, unfortunately, I'm not sharing, so I cannot point out the areas, but for babies who are less than 28 weeks gestation, less than 23 weeks gestation, if you look under the top, yes, on this flow chart, you'll see at less than 23 weeks gestation, resuscitation would not normally be carried out. And then at sort of 23 and 24 weeks gestation, there could be assessment and care consistent with the parents' wishes. And next slide. So the two, and next slide, so the two most important areas in this are less than 23 weeks resuscitation wouldn't be normally carried out. And there's also mention about caesarean section being rarely indicated and should only be considered if fetal compromise occurs at later gestations. And this is interesting based on what Nigel has just been talking about. And also the red box at the top, there was no mention of place of birth on this framework from 2009. So next slide, please. So what has changed 11 years on in 2019-2020? Next slide. Well, first of all, yeah, you can get that, that's great. So first of all, outcomes for preterm neonates have changed, and also the practice has changed, both the clinical practice and the clinicians' attitudes to practice. And alongside this, there's been a change in parental expectation and also knowledge. And we have seen, you know, a number of parents, high profile cases, including for extreme preterm babies, where parents have challenged medical management of their babies. Next slide, please. So this slide, and again, I apologize that I can't put the pointer along to it, compares the results from the Epicure 95 study to the Epicure 2 study, which was from 2006. And it's about probability of survival. And if you scroll along the top, look along the top, this is for admitted babies at 23 weeks on the left, 24 weeks in the center, and 25 weeks on the right. The red dotted line is 1995, and the blue straight line is from 2006. Next slide. And so you could, oh, sorry, previous slide. And you can see that in 2006, that for 23 weekers, there was a probability of survival of 30%, which was similar to the in 2006, which is similar to the probability of survival for 24 weekers in 1995. Now, this was just for babies surviving within the first 7 days. And if you look at the bottom 3 boxes, they were for up to 120 days after birth. So the survival margins were smaller, but still there has been an increase in survival over that time. I just want to bear in mind that those data, those 2006 data, are from almost 15 years ago as well. Next slide. So this slide shows survival to NICU discharge according to gestation from 1995. If you look along the x-axis, you'll see it going from 1995 to 2015, with the survival to NNU discharge represented as a percentage on the y-axis. The green bottom line is for 23 weeks, and it shows from increase in survival to discharge, almost doubling or more than doubling in that 20-year period. And if you look at the orange one is 24 weeks, which again, there's an increase in survival over that time period, and a smaller increase for those babies above in the grey line born at 25 weeks gestation. But I know you'll all be asking about, what about this 22 weeks gestation? So next slide, please. Thanks, Louise. And you can see this is from the same paper, which is from Nina Modi's group at Imperial, using the NNRD, the Neonatal Research Database. And they have looked at, again, this is survival to discharge as percentage on the y-axis, and time from 2008 to 2015 on the x-axis. And the blue bottom line, this is for 22 to 23 weeks gestation babies. And again, you'll see an increased rates of survival to discharge from NICU across 22 weeks to 23 weeks in that shorter period. Next slide, please. And this is just a more percentage change, again, looking at the time period from 1995 to 2014, comparing the EPICURE and the NNRD, National Neonatal Research Database data. And if you looked on the left-hand column, you'll see for babies, the top line for 22 plus 0 to 25 plus 6, survival rates within the NICU after admission to NICU are 40% in 1995, 53 in 2006, and 66. So a gradual increase across that time period. And Nina's Modi's group have also looked at the calculated annual percentage change, or APC, over this time period, and shown that for those babies between 22 to 23 plus 6 weeks, that the annual percentage change is around 6%. And if you look at that for on the line below, for 22 weeks to 25 plus 6 weeks, the annual percentage change has been calculated to be around 2.73%. So the greatest changes are being seen, this shows it, but there's lots of other data are occurring at those lower gestations. So, so next slide, please. Okay, so just bear with me while we go. This is an incredibly busy slide. So what I've talked about already is survival of those who have been admitted to the neonatal unit. So it's really important to consider the denominators that we're dealing with in this. So in 2016, Embrace looked at just babies presenting or born from 22 plus 0 weeks gestation up to 26 plus 6 weeks gestation for a 1-year period in 2016. And they used various denominators. They looked at, so if I take you just down to extreme left, if you see it across, you'll be 22 plus 0 to 22 plus 6. Again, apologies that I can't get the pointer because it's really important for this. But total births on that column were 486 babies born at that gestation over that year. Now, births alive at the onset of labour were 290. So there were a number of babies, a large number of babies who were dead at the onset of labour. In relation to live births, there were 183 of these. So almost half of babies did not survive labour at 22 weeks gestation. Of those babies who were delivered, of those 183 babies who were live births, 155, so 85% of those babies died at 22 weeks in the delivery suite. But if we go down to below, where you see babies receiving active care, 43 babies received active care. So 23% of the whole cohort of those who were born actually received active care. And out of those who received active care, 28 or 65% actually were admitted to the neonatal unit. Now, remember that number because I'll talk about it as we go on. If you look at 23 weeks, this is slightly better. Again, if we go down, we'll find that 83% of babies were actually born live after the onset of labour. There was a much lower percentage of delivery room deaths at 26, but 88% of babies actually received active care. And of those babies, 88%, 85% were admitted to a neonatal intensive care unit. So if we go across, Louise, just to that, where if you stay on that 88% at the 23 weeks and just scroll right across to the 24 weeks, 25 weeks and 26 weeks, we'll see that the percentage of babies receiving active care actually increased to essentially all babies receiving that. And the line just below that, nearly all babies surviving to be admitted to the neonatal intensive care unit. So next slide, please. So this slide, apologies that I haven't got the gestation going along the top, but where you see that number 28, who are the babies who were admitted after receiving active care at 22 weeks. If we scroll down that column, you will see that the percentage of babies surviving to 1 year, of babies who were alive at the start of labour, there were only 5%. But bear in mind that almost 50% of these babies actually died during labour, and only 23% of those born actually had some form of active resuscitation. So most of them, we can assume, would have died after delivery or were given comfort care with the family. But the interesting thing is, if we go right down to the bottom, the percentage of those surviving to a year who were admitted to the NICU, that 54% of those survived. Okay, and again, we see that that increase exponentially. So that's 22 weeks. But if we go across the scale, we've got 23 weeks, 24 weeks, and 25 weeks, and 26 weeks. So we see that the percentage surviving at 1 year following admission to NICU actually increases to 84% at 26 weeks gestation. And if we look go up to the darker purple line where it says 34% under 24 weeks, the percentage surviving to 1 year of all live births, we can see that if we move to the right of the screen, that those numbers are also increasing. So there have to be some caveats around this as well, that this was just a 1 year period and that these were very, very small numbers of 22 weekers. So that graph is a lot to take in, but that's actually in the Embrace report and easily to find the whole graph. That's the one graph, the table split into two. So next slide, please. So this really just shows you graphically the survival according to different denominators that you're using. So the percentage survival is on the y-axis, and along the x-axis you've got various, Legend has various color codes, with 22 weeks being in yellow, 23 in the teal diamond. And AOL means alive at the onset of labour, and then percentage survival. the active means active percent who survive following active management following delivery, and then admission is the percent of babies who survive following it, who are admitted to a neonatal intensive care unit. So as we've seen before on that embrace chart, we know that a large number of those at 22 weeks, almost 50%, will actually not survive labour itself. So I'm not suggesting they have cesarean section by any means, but these data just really kind of clarify pictorially what we saw on the previous two slides. And it will help if you were, talking and sharing with teams or discussing with teams to help them understand what we're really talking about. So next slide, please. Next slide. So like for us in neonates, as in obstetrics, we are very busy benchmarking both nationally and internationally. So really we need to see, as Nigel showed, how do we compare with the rest of the world? And so how do we compare in the rest of the world in relation to survival at different gestations? And so again, y-axis is percentage survival and the various gestations between 22 and 26 weeks along the x-axis. UK is in yellow. I'd just like to point out that Sweden is in pale blue, and this is relevant given Nigel's previous talk about the high rates of caesarean section in Sweden. So pretty much an increase in survival rates as gestation increases up to 26 weeks. So next slide, please. So what determines who actually gets resuscitated? And I've talked already that outcomes have changed, attitudes of clinicians have changed, and parental perception has also changed. And this shows it's a 2016 survey that shows that 40% of UK neonatologists would actively resuscitate at parental request babies at 22 weeks gestation. And next slide, please. And this is from an American paper, and this shows the provision of active care given to babies depending on the gestation that they're born at. Percentage on the y-axis, gestation along the x-axis, and you can see that as the gestation moves on, the babies are more likely to have active care. And what's quite interesting, next slide, as you move to later on in gestation, so you're getting to 22 plus 5 or 6 weeks, and next slide, and 23 plus 5 or 6 weeks, those babies at the later gestation within that week are more likely to be resuscitated. Next slide. Next slide. Thank you. So again, this shows, this isn't about survival, this is the percentage of babies admitted to the NICU, which will be a reflection on the, not just survival of the resuscitation, but also will reflect certainly at the earlier gestations, whether active management is actually performed. And you can see on the x-axis again, you've got a time range from 1995 to 2015, and you see that there are many more babies are now being admitted at 22 weeks gestation, which is the yellow circle, and also at 23 weeks gestation, which is the hexagon, is it? No? So, no. And then the triangles are 24 weeks. So the greater changes are being seen at those earlier gestations. So next slide, please. So as Nigel very rightly said, it's not just about survival. In the longer term, we certainly need to think about disability, and in particular, severe disability. So again, this slide shows the percentage of severe disability across countries, England, Sweden, again, England yellow and Sweden in the light blue colour, and America as well. from 22 weeks to 26 weeks gestation, so that you can see that at around 22 weeks gestation, that around a third of babies will, of those who are surviving, will experience severe disability. And this would be categorized as severe cognitive impairment, severe cerebral palsy, or being unable to see, or severe deafness. And again, these ranges decrease as the gestations progress. Next slide, please. So it was timely then. I just want to talk about the new BAPM framework that came out in 2019. And given these increases in survival, it was really timely for BAPM to look 11 years on at what sort of management we should be looking at in a framework for extreme preterm birth, and this time before 27 weeks gestation. And they worked with a number of other organisations and groups, including the RCOG and Embrace, on this project. Next slide. Next slide. So what was the approach that was taken? Well, it was a risk-based process for decision making, which took into account gestational age. Next slide. And factors which modified those risks. Some of those risks were fixed, and again, some of those were modified. Next slide. There was then informed consultation with parents, and this is really where shared decision making comes in, and back to where Nigel was talking about working with parents to explain everything to them. And next slide. And then really, really important to agree and have communication around a management plan for the labour and delivery, and also for the management of the baby afterwards. Next slide. And as part of this management plan, and these two lines are very important in relation to BAPM, because the management plan would either determine whether it would be active care, which is survival focused, or palliative care, which is comfort focused. Next slide. And finally, to highlight that plans may change. So you might have a plan around active care, but in fact, when the baby is delivered, the baby may not be in a particularly good condition. And at that stage, the care may be reorientated to palliative care. Next slide. So what are the risks affecting survival and morbidity? And these are really important to take into account if we're thinking about whether we provide active care or whether we start providing palliative care for these babies. So as Nigel mentioned, and we've seen on these charts, that lower gestation is obviously a high risk for lower survival and morbidity. Chorion amnionitis can affect the outcome, growth restriction, maternal obesity, or whether the mother is a smoker, can have a huge impact for all sorts of reasons. Place of birth is particularly important. Tertiary centres, because we really want to avoid ex utero transfers because of the both mortality and morbidity risks. And there's been, a number of recent publications in relation to this. And finally, the antenatal steroids and the magnesium sulfate, which Nigel has also mentioned. Next slide. So what BAPM did is they came up with a sort of traffic light system where you go from a dark orange to a green. And the dark orange is considered extremely high risk category because it's a risk-based approach. And the orange is a high risk, and the green obviously moderate risk. So under extremely high risk, the categories of which babies would be included in that would be those where there is a greater than 90% risk of death. And that risk is if actively managed, not if the baby's left, but if actively managed, or there's a greater than 90% risk of severe impairment. High risk would be where there is a 50 to 90% risk of death or severe impairment, and moderate risk is where there's less than a 50% risk of death or severe impairment. Next slide, please. Okay, so please bear with me. There are 3 levels in this, and you move from left to right. So first level is assessing gestational age. Second one is the presence of non-modifiable risk factors. And the third one is assessing modifiable risk factors. And don't worry if you're looking at this and thinking, oh, I can't get my head around this, because actually the more you look at it, the easier it gets and it makes sense. So it makes sense, obviously, that if you look at the gestational age category up at the top, and again, apologies, I can't use my pointer, that if you're born at 22 weeks, that this is extremely high risk, but you become moderate risk, so less than 50% chance of severe outcome at 25 and 26 weeks gestation. And if you go down to the next sort of band of red going to a lighter colour, you'll see that gestational age, that if you are born at the beginning of your gestational week, that puts you at higher risk. So those are 22 plus 0 or 23 plus 0 are obviously at higher risk. Where there's fetal growth restriction, where the male sex or multiple pregnancy, and these are non-modifiable risk factors. And then if you go down to the bottom band, these are modifiable risk factors, where we know that if the baby's had no antenatal steroids versus a complete course, that can affect the outcome. And also where the place of birth, the setting for birth, if the baby was born in a non-tertiary centre versus if the baby was born in a centre with a NICU. So what does all this mean, and how can we sort of make sense of this and come up with categories? So next slide, please, Louise. Okay, so again, on the left, you've got the extremely high risk, which is the dark orange, the lighter orange, high risk in the middle, and then the moderate risk is the green on the right-hand side. So if a baby, and I will go through which babies would fit into each category, if a baby is in the extremely high risk category, life-sustaining treatment should usually not be provided. And it's important to have a discussion with the parents and confirm that management with the parents, so that palliative management can take place with the multi-professional team following the birth of the baby. If the baby's in the middle category of the high risk category, this is 50 to 90% risk, life-sustaining treatment can be offered, and there's sort of shared decision making, and this can be based on individual assessment and informed by parental wishes. So for example, if this was, parents might say if this is their only chance to having a baby, they might want everything done. So a discussion and shared decision making to decide which way, whether we would look at palliative management or active management after delivery. And bear in mind that that could change depending, because a baby may not be the way we might expect that baby following the delivery. And finally, the moderate risk on the right, where life-sustaining treatment should usually be provided, and this is confirmed with the parents. Active management is provided, but if the baby presents in a different way, that the care could be reorientated to palliative care at any time, again with discussion between the team and the family, the parents. Next slide, please. Next slide. So this is just what it looks like in practice on the top, and this is lifted from the BACM framework. Those who are extremely high risk would be, for example, babies at 22 plus 0 to 23 plus 6 weeks gestation who have unfavourable risk factors. So they're early on in the gestation, they haven't had steroids, there might be growth restriction male fetus. High risk would come under babies at 22 plus 0 to 23 plus 6, where they have no unfavourable risk factors, or babies greater than 24 weeks with unfavourable risk factors or comorbidities. And then finally, the moderate risks, an example of those babies would be most babies greater than 24 weeks gestation, or babies at 23 weeks, any type of 23 weeks gestation, but those who had favourable risk factors. And again, if anybody's hearing this for the first time, please go back and read it, because it does make more sense. First time I saw all this, I was just trying to get my head around it. So next slide. And again, this is what Nigel's shown, that this is a very good infographic that has been published by BAPM for use with trying to explain to parents, because parents might just, want to, 7 and 10 or percentages might mean more, and we all look at figures in different ways and they mean different things to us. So it's important to go through both survival and, of course, disability, and what that disability could mean for families, so that we make it very clear to them. Next slide. So who explains all this to the parents? Well, obviously, again, as Nigel said, the perinatal team, obstetricians, midwives, and the neonatal team. And this really sort of crystallizes and cements the importance of joint working and also joint planning of care. Next slide, please. And again, this is the perinatal optimization pathway, which is part of the BAPM Quality Collaborative. And Nigel's already gone through this with you, but on the left-hand side of the screen, you'll see the prediction of preterm birth. And then the next blue circle is optimizing antenatal care, and then we've got peripartum optimization, looking at optimal cord management, normothermia, and maternal breast milk. And BAPM are bringing out and have already brought out a number of toolkits around this quality collaborative, so that we can look at improving outcomes and providing the best care for babies. So I'm just going to look at the antenatal optimization pathway in a little bit more detail. So next slide, please. So this is the toolkit from BAPM for antenatal optimization, which has just been recently published, and there are sort of 5 main areas to this. So obviously accurate prediction, and we've talked about the QUIP app earlier on this evening, and the importance of that, particularly alongside optimizing both the timing and the place of birth. So you don't want to transfer somebody and they'll be sitting on another tertiary unit for a week and then get discharged and come back 2 days later. So prediction is really important, and being in the right place at the right time. Steroids, magnesium, and antibiotics for those in preterm labour or pre-prom is also important. So next slide. So despite plans for active management and carrying those out, there may also be a decision for palliative care. And just to really briefly touch on this, because this will probably be planned in advance, or there'll be a decision as a baby is in poor condition. It's important to discuss the possibilities in advance, and for the team to plan around that palliative care might happen even if there has been a plan for active management. It's important to support the family and ensure that the baby is comfortable, that the team are involved in memory making. And one area I'm involved in at the moment is managing lactation and loss, and we're going to be coming out with a national guideline on that. Again, support for staff, and the brief and the debrief is really, really important, because we've certainly shown in our team that by having a pre and post resuscitation brief and debrief, that improves communication and confidence within the team. Follow-up support, and also a preterm or early birth clinic, we're seeing those increasingly available for parents. Next slide, please. So how do we actually improve the outcomes? We know what we need to do, but it's actually getting it into practice. And so we need to look at continual quality improvement. As I've mentioned, the place of birth is important. Within your own teams, it's really important to look at your NNAP and the VON data. And I would say for the perinatal team to do this jointly. And this could be undertaken during joint meetings to review your outcomes, and to really talk about, what could you do better, to have some sort of exception reporting for babies who are non-tertiary unit born. Look at exception reporting also around antenatal steroids or magnesium. And use the BAPM toolkits and look at where things are being done well. For example, the London IUT programme or the Oxford programme for place of birth are really good. Precept and the peri-prem programs are also excellent. And it's important with any quality improvement program that you built in sustainability into it, because quick wins are all very good, but it's important to try and avoid quick fixes, because you may end up back where you'd started. Next slide, please. And finally, I think this is the fluffy but important bit. And I think it's really important to have situational awareness and stop thinking, you know, it's not about them and us, but really we all, obstetricians, midwives, anaesthetists, neonatal team, we have to become one collective perinatal team. Joint meetings, as I've mentioned, and communication, which is timely and clear. And there's been a lot written recently about how the neonatal units, where there is good team working and a good psychological safety, a good culture, actually have improved outcomes for their babies. And that's often been referred to as the secret sauce. And I was very pleased to see also recently Mary Dixon Wood's paper in the BMJ about the 7 features of safety in maternity units, which really concentrated on communication and psychological safety within the whole team. And finally, you might not think that what you're doing is making any difference, but marginal gains have been really, really important and could be important for a family. They might be the difference between the type of support a child needs at school or whether they'll make the football team or not. And I don't know if many of you are aware about, you know, the concept of will it make the boat go faster? And if you look at British rowing team, have always been incredibly successful, as are the Irish more recently. But you know, teams look at how they can actually improve how they can work, what little tweaks they have to make to actually make their boat go faster. So I think it's always worth thinking how we can continue to improve things whilst working within the maternity and perinatal team. So next slide, please. Louise, thanks. And I just finally like to say thank you to everybody who was on the both the framework and also the team who worked with me, and especially Julie Claire Becker on the antenatal optimization toolkit. Please look out for the more toolkits coming online to improve outcomes, and do join BAPM. Thank you, Louise, and thank you everyone else.
That's brilliant. Cora, thank you so much for that amazing talk, and it's definitely going to influence how I counsel my patients. We are slightly running over time, so I'm not going to take any questions. Yep. What I might do is get some of the questions answered from the chat and disseminate it through the email group that we have for BICS. So what I'm now, so we've had a sort of journey on the woman presenting with threatened preterm birth. How do we deliver these babies? What are the sort of important management and resuscitation? And now we're going to talk about supporting the women who are at risk of preterm birth, and the role of midwifery continuity of care from this. So I'm going to now turn to Cristina Fernandez Chirienzo and Jane Sandall, who are a midwifery team from King's College in London, who are going to talk about the pilot trial that they've had in this area. Thank you. Jane, can I ask you to share your...
Yes, I think Christina's presenting.
Okay, Christina, yes.
I'm just trying to share the screen.
The Zoom gremlins have been out in force tonight, so let us know and we can bring up the slides for you if you need to.
Yeah.
We'll try to be as quick as we can, but I'm not sure how much we can squeeze into 10 minutes.
I don't think many people have stuff to do, so I'm very happy to carry on. I think a lot of people really want to hear the sort of valuable contribution that midwifery can play in these group of women, to be honest. So we can run over time if that's okay with you two.
Mm.
Yeah, I cannot share the screen. I don't know why. If you are happy to
Louise, are you able to bring up the slide? Thank you.
That will be helpful.
Yeah, I've just asked Louise. We should bring it up anytime soon.
Thank you.
I don't have the slides, Eamon. So
okay.
Jane, I don't know if you can share them.
I can.
Thank you. Can you? Yeah, I don't know why I can't.
Yeah, sorry, I'm just taking them back to the beginning. Okay.
So, hi everyone, I'm Christina. I'm one of the researchers working with Jane at KCL, and I was coordinating the POPI trial, which was a pilot study to evaluate a new care pathway for supporting women who are at increased risk of preterm birth. This was done in South London, in Lewisham, and it was funded by the NHR in collaboration with the local authority, the CCG, and the local trust. So we'll just give you a bit of background on the study time-wise as we go quick through some of the slides. So Jen, if you can go to the next slide. So, well, this is just a bit of background in terms of health service interventions that may help reduce preterm birth. So there's evidence on, there was a Cochrane review that found that women who receive care by the same midwives or the same team of midwives during pregnancy, birth, and the postnatal periods were 24% less likely to have a preterm birth and 19% less likely to lose their babies before 24 weeks of gestation. And a more recent review, a more recent Cochrane review, which was a review of reviews, found that this was actually the only health system intervention that that improve preterm birth outcomes and perinatal surveillance. Although we don't understand very well how this works. If you, Jane, want to go. So this Cochrane review has had an impact on maternal policy in the UK and globally. So, you know, Better Births in England states that most women should have continuity of care by March 2021. And there is also a need to target PME women and those who live in the private areas. So the plan is by 2024 for at least 75% of women from PME communities to receive midwifery continuity of care all the way through. Yeah, sorry. So yes, there are gaps in the evidence. We don't really understand many things about how continuity of care models may work. On one hand, we don't know why there are less preterm births or fetal losses. Models of care are complex interventions, so they are not like a single or drug trial interventions, and they do require understanding of the relationship between the processes and the outcomes. We don't know much about the best ways to scale up and sustain these models in terms of the system support, in the maternity health system support, cost benefit, and workforce. And on the other hand, we don't really know whether these models of care are feasible in high-risk populations, particularly in women with medical or obstetric risk factors. And this was actually the basis for designing the POPI trial back in 2015-16 in collaboration with all the stakeholders. So there was high rates of preterm births in South London, in this area of London, and child mortality associated to preterm birth was also high. So we hypothesized that a model of continuity of care with a rapid referral to a preterm birth clinic was feasible and could improve experience and outcomes for these women. So we did a pilot RCT, which was hybrid. So it was effectiveness implementation. So we were not only looking at the clinical outcomes, but also we wanted to evaluate the whole implementation, whether the model was actually provided as intended. We included pregnant women, less than 24 weeks pregnant, who had one or more of those risk factors that you can see there. So previous cervical surgery, uterine abnormality, previous cervix, previous circlage, previous preterm birth, previous late miscarriage, and we also included smokers at booking. You can also see in the next slide the logic model. So this is the logic model that we use for puppies. So to develop the intervention. Not sure if you are familiar, but anyway, they are basically a graphic representation of the theory about how the intervention may produce outcomes, and they are particularly helpful for complex interventions like continuity of care models. So anyway, it's in the protocol published if you are interested. In the next slide, we can see how the model may work. So we think there are multiple potential mechanisms or hypotheses about how this model of care may work. So on one hand, having a relationship with the same midwife over time may increase women's perceptions of trust, of safety, professional competence and confidence, and may also provide midwives with more opportunities for early diagnosis and early intervention. And at the same time, women may feel less stressed, they may feel safer or relaxed or more support socially and emotionally. So within these models, midwives work within a network of support, so they can actually ensure advocacy and outreach for women, improve access to care and services and follow-up. And if fidelity to guidelines are ensured, then we can get better coordination and navigation and referral, which can lead to better access. Anyway, in the next slide, we can see the models of care in both arms of the trial. So women in the puppy arm, in the intervention arm, receive continuity of care during the antenatal, intrapartum, and postnatal care. This was provided by a named midwife who worked in partnership with a partner midwife, and they were backed up by a team of 6 midwives in total. They provide care in different settings, in hospital, in the community, at home. Important things, they did have weekly team meetings for discussions of cases or reflection. They did about 2-3 on-calls per week. They do provide antenatal classes and offer home labor home assessments. The team had also a link obstetrician, so they could contact for any queries in relation to clinical issues. And then we have women randomized to standard care who receive just maternity line in maternity care in line with usual practice at the hospital. So basically the obstetric care was the same in both arms. The only thing that changed was basically the midwifery pathway. If we go to the next slide, so this is an overview of the clinical and process outcomes, as well as implementation outcomes on the right that we were looking at. So the study, the study is a pilot trial, was not powered for preterm birth. So the primary outcome was a composite of interventions provided for the prevention and management of preterm birth, like antibiotics for uterine infections, cervical scans, fetal fibronectin testing, circlage, progesterone, magnesium sulfate, and so on. So we thought that, we hypothesized that initiation of these treatments will be earlier, or not earlier, but a more appropriate time in women in the puppy group, because the midwives have better knowledge and lower barriers for women, and perhaps faster access to obstetric opinion and management. And then, of course, we also look into other secondary outcomes, which included the labor and birth outcomes and postnatal outcomes for mother and babies. We also look at women's physical and psychological well-being, health in pregnancy and complications, and experience of care. In terms of implementation, we also look at main implementation outcomes of research in terms of is the model feasible and acceptable for midwives and for the organization, can be implemented in practice as intended, fidelity, are we reaching the population that we are targeting, if the model is successfully diffused into practice, if it's sustainable, cost effective, and so on. And then in the next slide, I'm not going into details, but this is just a summary of all the qualitative and quantitative of the qualitative and quantitative data that we were collecting to measure all those outcomes. So in terms of, results. So in terms of the results, so over a period of about 18 months, we recruited a total of 334 participants, and 169 were randomly assigned to the POPI and 165 to the standard group. Attrition was generally low, about 6% in both groups. So only one woman withdrew from POPI, and 2 women were lost to follow-ups in standard care. So in terms of feasibility, we could say that the POPI model was feasible, was acceptable, and attrition rates were okay. In the next slide, we can see the fidelity results. Again, fidelity was good. Actually, more than 85% of antenatal and postnatal visits were provided by a POPI midwife for women in the POPI group, and nearly 75% of those were provided by the name and partner midwife. And a POPI midwife was present in about 80% of births. So in terms of standard care, there was some continuity of care during the antenatal period. Half of women got appointments with the same 2 midwives, but the real differences came during the intrapartum and the postnatal care. In terms of baseline characteristics, there were no real differences between both groups. Mean maternal age was about 31 years old, and there were 32% of women were from Black, Asian, and minority ethnic groups, quite representative of the local population anyway. And what else? Then in the next slide, we can also see that we are dealing with kind of a high-risk populations in terms of medical and obstetric risk factors. So more than a quarter of women had at least one pre-existing medical condition, and multiple risk factors for preterm birth, obstetric and social. Just about 30% primary outcome. In terms of primary outcome, the proportion of women, there were no really difference. The proportion of women who had any clinical interventions from the primary outcome was similar in both groups. Even when we look at the time and appropriateness of the interventions, there was no difference between groups. In terms of maternal outcomes, again, there were no many differences. Well, in terms of complications as well. Sorry. Again, there were no difference in complications in pregnancies either. Maternal outcomes, again, no big difference in onset of labor, pain relief, mode of delivery. We can see some proportions, but there's no significant difference. So nothing. And in terms of place of birth, again, very similar outcomes in terms of place of birth, intrapartum transfers, admission to ICU or ITU, OHDU, sorry, again, was very, very, very similar between both groups. Neonatal outcomes, again, very similar outcomes. No big difference. No big difference in APGAR, in birth weight, in preterm births, delayed cord clamping, and there was, however, in the next slide, we can see some difference in women in the puppy group were more likely to have skin to skin, have it for a long time, and also having breastfeeding at hospital discharge. So these were the only things that we found to be significant. But again, it's an empowered trial, so it's a bit difficult to interpret there. And I don't know, Jane, if you want to go through any of these. Or...
Yeah, so I think we really want to think about the implications of this. So it is possible to set up a continuity of care model for women who are increased risk of preterm birth in a trust actually which hadn't had continuity of care at all before. It's possible to set up, run and recruit and retain to a trial, and it's possible to implement that model with fidelity. It was an underpowered trial, it's a pilot trial, but I think the lack of trend as well is interesting, and we have thought about why this may be. It's possible that because there was a policy push, that there was more attention, and because we had Saving Babies' Lives, there's more attention to women who are high risk of preterm birth in the trust. There are also some differences postnatally, and the actual difference in the level of continuity of care antenatally wasn't so huge, and where the big differences come are in the postnatal period. So the mechanisms that we thought through about trust and engagement, about improved care coordination, we're analysing some of those outcomes now. But our thinking is maybe this isn't the best, if you can only give these models of care to some of your population, maybe this isn't the population that would benefit most, although we would argue in the postnatal period, if a woman does have a preterm baby, there's a big difference in women's experiences of care because they have the same midwife continuing to support the woman through to 6 weeks. So our thinking is, if you're going to do this in the future, or future research gap is really around women who fall through the gap, who find care hard to access, where having coordination and advocacy could make a difference. And so certainly women who are living in socially disadvantaged areas, or women who have multiple complex social factors. So as I said, at the moment we're looking at the experiences of maternity care that women had. We've done qualitative and survey data looking at their experiences, and also looking, publishing the implementation analysis. I'd like to acknowledge all the team. It's a big team from King's, and I'd also like to acknowledge our trial steering committee, of which Nigel was the chair. And thank you very much.
That was a really interesting talk. Nigel's just asked, when do we expect the qualitative results, i.e. women's views, to come through?
Oh, so over to you, Christina.
Yes, they are under review at the moment in +1, so hopefully soon. but there are a bit of delays in the reviewing process. So yes, but hopefully we
Yeah.
can complete soon.
So the trial paper is published. It's in PLOS Med. The protocol is published in Trials, and there are more papers to come through. And I think particularly women's perceptions of safety, and as I said, their experience of postnatal care is particularly, I think, strikingly different. And picking up on a point you made earlier about care of women who are high risk, we have some teams for high risk women at St Thomas's, but they tend not to go into the postnatal period. And my hunch is with women who have medical complications, who may have diabetes, hypertension, epilepsy, when they go home, it's the postnatal period where they need the care most, where those high-risk teams stop. So I think that maybe might get you biggest bang for buck with high-risk women.
And the women who were studied in this trial, are you planning to review them sort of 6 months on to look at their sort of mental health and risks of postnatal depression?
We looked at their health and well-being, and we looked at some postnatal psychometrics. That was at 3 months, 3 to 6 months. We have permission to go back and contact them, and it will be a year now, and we'd love to follow them up and to follow up their babies, but we need the money to do it.
Absolutely. I think that was an amazing trial. And in terms of, somebody's asked about implementing continuity of care as it is, sort of what do you think the biggest challenge will be now in implementing continuity of care now that we're all being tasked to do so? Is it...
I think in times of COVID as well, although it's interesting across the country how some trusts have kept up their continuity of care teams, particularly targeting women who find services hard to access, doing virtual care with those women. And I know Chelsea and Westminster have managed to do that, and so has Warwickshire. I think the challenge is having a sustainable model. So, what is good enough to make a difference? And there's certainly learning from the Cochrane systematic review we did, but there's also learning from the Poppy trial in terms of how the model worked and the implementation of it, where you can achieve enough fidelity without burning out the midwives. And I think there are a lot of lessons from that as well.
Brilliant. Jane and Christina, thank you so much for agreeing to give that amazing talk and for staying past the designated time. We really appreciate it.
Welcome.
We are now at the end of our webinar session on preterm birth, and I hope you all agree that those talks were fascinating and definitely will be implementing my practice sort of from tomorrow and onwards. This is the second in a series of webinars that we're running throughout the month of November, and the next one is next week. I'm just going to bring that up. And that is when we are looking at the Black, Asian and minority ethnic staff, service users and their allies, and understanding the current challenges in maternity services. We will have copies of the recordings on our website for BICS members, and we'll also be sending out a feedback questionnaire, which we would really appreciate you filling in so that we can try and adapt things and learn from the webinar series as we're going on. And hopefully we will all see you in Belfast in 2021 face-to-face for an actually a non-Zoom platform and share a drink, etc. So thank you very much for everybody for speaking, and good evening to everybody. Thank you.
Yep.